Today's topic is diabetes insipidus, and I think the most important thing that we need to start with is the difference between diabetes insipidus and diabetes mellitus, which would be the most common one that you're going to see in practice anyway. So diabetes mellitus is just the inability or the decreased ability of the pancreas to produce insulin, which creates an increased blood glucose. Okay? But diabetes insipidus is just the inability for the kidneys to conserve water and concentrate urine. So diabetes insipidus has nothing to do with the pancreas, insulin, or blood glucose. The reason they're both called diabetes is just because they both cause increased thirst and urination. That's all. So the physiology of it, ADH is a hormone that's produced in the hypothalamus of the brain. It's also called AVP, or arginine vasopressin, and those terms can be used interchangeably, so it's important that you know both of them, just in case you're reading something that uses AVP instead of ADH. Okay, so what does antidiuretic mean? What's a diuretic?
Antidiuretic would be something that reduces polyuria, so assuming antidiuretic would be something that conserves.
Yeah, that conserves water, right? Yeah. So once this hormone is produced in the hypothalamus, it's then stored in the posterior pituitary gland. And then when dehydration is detected through receptors in the hypothalamus, it's released from the pituitary gland, and that acts on the kidneys to conserve water. So patients who have diabetes insipidus, they either don't produce enough ADH or their kidneys just don't respond to it for whatever reason. Okay, so clinical signs of diabetes insipidus are polyuria, polydipsia, and urinary incontinence. So we all know what those mean, right? PUPD is increased urination, increased water intake, and it causes urinary incontinence just because there's such a high demand on the bladder to contain that increased volume of urine, so they're leaking urine. So there's two forms of diabetes insipidus. There's central, which occurs in the brain, and then there's nephrogenic, which occurs in the kidneys. Am I going too fast? Okay. Because I know you don't have the PowerPoint, so I want to make sure. Okay. So central diabetes insipidus is the decreased or absent production within the hypothalamus and pituitary gland. This being the primary disease is really uncommon, and it's usually an acquired or secondary disease to some sort of damage to the hypothalamus or pituitary gland. So that could be head trauma, like hit by car. It could be some sort of cancer within the brain, either a primary brain tumor or metastatic brain tumor of some kind. It could be loss of oxygen to the brain during like cardiac arrest. There you can also have cysts, infection, inflammation, or it could be caused by Cushing's disease. And the idiopathic form of it is the most common, just meaning we don't know why. Because diagnosis of this disease can be pretty complicated. So the form of nephrogenic diabetes insipidus is just that the kidneys are not responding. Even though the body is producing a normal volume or even increased volume of ADH because it notices that the kidneys aren't responding, the kidneys are not conserving water, and it's being lost through the urine. The most common acquired or secondary reason for this disease would be Cushing's disease, pyelonephritis. Do we know what pyelonephritis means? Anybody know? Means kidney infection. And hypercalcemia, so increased calcium level. And the congenital form of this, the primary form, just like central diabetes, is super rare. If they do have this, if they're born with it, they end up showing symptoms of this disease around 8 to 12 weeks of age. And their prognosis when they have primary NDI is pretty poor, just because they're going to be super prone to dehydration as a young animal, low blood pressure, and so on. So diagnosing diabetes insipidus is really just making sure that the patient doesn't have any other diseases that cause the same signs. There is no definitive test for diabetes insipidus. You know, it would be nice if there was a SNAP test like heartworm disease or like a CPL SNAP, but there just isn't. So the doctor has to rule out a bunch of other diseases before we can come to that conclusion. So what are some things that cause PUPD? Can we name some?
Salty diet.
Sure. Yeah. Some other diseases that cause it?
Kidney disease.
Yeah.
Prednisone.
Sure. What else? So there's kidney disease. Obviously, diabetes mellitus causes increased thirst and urination. Cushing's, we already talked about that one. Addison's disease also causes PUPD. Hypocalcemia, or hypokalemia, sorry. Liver disease can cause it as well. Pyelonephritis, a kidney infection. Pyometra causes PUPD. And the reason that happens is because of E. coli, which is the most common reason to have pyometra, is E. coli infection within the uterus. It kind of blocks the effects of ADH, so they become PUPD. Hypercalcemia, and then psychogenic polydipsia. So psychogenic polydipsia is a disorder that dogs get. Psychogenic meaning it's like a psychological problem where they're consuming too much water. A lot of the time it's caused in dogs that are super hyperactive and are not being exercised appropriately, and so they start developing like psychological issues. Okay, so the first thing we have to do when we're diagnosing this is confirm the PUPD. And this requires measuring the water intake over 24 hours. And this is something that the pet owners are going to do at home. So a lot of the time, you'll instruct them over the phone. They'll call in, or you'll call with their lab results and say, hey, it's not kidney disease, it's not hypercalcemia, it's not liver disease, all of those things are normal. So now we need to measure the water intake to make sure the patient is actually drinking an increased volume of water and urinating in an increased amount. That way we can make sure that it's not something like it's just really hot outside and the patient is drinking more water than usual and it's an actual like pathologic problem. So the owner will give the patient a certain amount of water, like measure it out, and once that patient drinks that much water, they'll write it down, they'll give them a certain amount again, and so on. And if the patient is drinking more than 100 mils per kg per day of water, then that is an increased volume of water intake. And measuring urine output is a little more tricky. That's probably not something an owner is going to do at home. It would be something that we would do in the hospital. Depending on the state of the patient, maybe they would have a urinary catheter in, and then we would be measuring, urine volume that way. So if they are truly PUPD, what do we do next? Well, we need to test their urine. We need to make sure there's not a UTI. That's a super common cause of increased thirst and urination. And make sure they don't have pyelonephritis. If a USG is super low, we need to determine if that is a chronic problem